Hello, this is Neuro Tutoring. I'm Stacy Hunter, and this is going to be one of two sessions for exam one. Okay, so we're going back to MGA again and looking back to our favorite subject, embryo. So in about day 18, we have the formation of the neural groove, and we've got the neural crest cells that are going to be folding and forming this groove and fold, which should develop into the neural crest. By day 21, we've got the neural tube that's formed right here. We can see that it closes cranially and caudally from its initial closure in the cervical region. And so our spinal cord development at around 8 weeks, you can see that our spinal cord goes all the way down. But as we reach adulthood, our spinal cord ends around L1. And so as we progress from 8 weeks, 24 weeks to newborn, we're already seeing that the spinal cord the spine is increasing in size, but the spinal cord isn't. And so we've got this phylum terminale that is left behind, attached here right at S1, and our spinal cord is going up. So this is going to be important as we find some clinical correlates, like tethered cord. So this can occur with surgery because of repair of meningocele, or it can occur because of other reasons. The spine doesn't develop properly, and so it limits the movement of the spinal cord. So if you think about it, and if we had a cord that was really tight and it was pulling, and we're trying to pull it tighter and tighter. If you think of like a rubber band, and if you keep pulling and pulling and pulling and pulling, it's eventually going to break. And so that's sort of how like this does. So it pulls and pulls and pulls and pulls, and it causes that progressive neurological disorder. And surgery can release this tethered cord. So if we look right here, back at this picture, if this is increasing, but our phylum terminale is being stretched too much, we can have damage to our spinal cord. So we're going to have progressive sensory and motor changes, incontinence, back, lower limb pain, and they also may have scoliosis. It's trying to compensate. So this traction causes ischemia in the lumbosacral regions, and there'll be impairment of mitochondrial oxidative metabolism in the lumbar sacral neurons. Spina bifida is something else that we might see. So it's a defect. We can see right here a defect in S1, and we can see a defect in the posterior arch of C1. So a spina bifida occulta, everything's together except this vertebrae never fused, and we're left with a tuft of hair. So if you're going to the NICU, or going even like after a baby's born and you're rounding and you're looking, they always turn the baby over prone, and they look and see if there's any dimpling or any tuft of hair to look for spina bifida occulta. When we have spina bifida with a meningocele, that means that our dura mater and our subarachnoid space containing our CSF is going to come out, and we'll see an outpouching over the skin. However, all of our neurological structures are going to remain where they were supposed to be, right there. Our spinal cord will be right within where the arch would have kept it. So this is kind of a diagram picture of what a meningocele would look like. This is less serious than a myelomeningocele, so make sure that you know the difference between it. A meningocele only has that pocket of fluid. A myelomeningocele has the neural structures in it. So they have incomplete paralysis, bowel, or urinary control issues. And right now I'm doing a neurosurgery rotation, and we've got a few babies right now in the NICU that had this repair. So this is our myelomeningocele, and we can see that all of our structures are out here. Myeloschisis is an open myelomeningocele, so we're open to the air, and so these spinal cord could be definitely hurt more than just a myelomeningocele. Here's just the definitions again, so you can look at it. Here's a baby. This is what they look like when they come out. So diagnosis. So later, and as you get along in OB second semester, you'll learn about some of these things like alpha fetoprotein and some of the other screens that they use. But the maternal serum, they're going to test a few things. And so if our AFP is high, then that can indicate a spinal or a gastro issue. So I would probably know that alpha fetoprotein is important. So now we're going to talk about Chiari's. So Chiari 1 is going to be just the tonsils are going to be displaced. But a Chiari 2 is a lot worse. The full name is Arnold-Chiari malformation. So Arnold-Chiari 2 is going to occur greater than 75% of the time with myelomeningocele. So the cerebellar and brainstem tissue protrude through the foramen magnum. So they'll have neck pain, balance, muscle weakness, paresthesias, difficulty swallowing, headache, and vomiting. And we'll talk more about Chiari in a little bit. They also can be hydrocephalic. So there'll be excessive accumulations of CSF. And so that leads to an increased head circumference. So the treatment is going to be a shunt or putting, or what's called a ETV, which is an endoscopic third, it's a third of ventriculostomy. So basically, what all this means, so if we think about, I don't think I included a picture, but if we think about the lateral ventricles, they're sort of in the middle of the brain. So what hydrocephalus would look like is, let me see if I can just Google it real quick. It would be a huge, huge space. And this is the majority of what pediatric neurosurgery deals with. I'm going to include a few pictures real quick. Okay, so here's hydrocephalus. This is what the baby would look like. Really big head. And then we've got ventriculomegaly. And then right here. I think you can appreciate it better when you're able to see it. Okay. So we've got increased CSF. The most common cause of hydrocephalus is actually going to be aqueductal stenosis. But in this case of myelomeningocele, we've got all the CSF. Now we've got it coming out our spine, and then we've got a huge space in the brain. So as you can see, the actual brain tissue is going to be compressed by this huge space of fluid. And it leads to this really big head because our sutures aren't closed yet and our fontanelles are open. So it allows the skull to swell. And so we'll look at the shunts. So they make a little incision in the head. They put this drain into the big ventricle, and then it's got a little valve and it goes down to the stomach and drains out just into the peritoneum. Anencephaly is going to be where they have rudimentary midbrains, but there's no hemisphere, cerebellum, or meninges or skull. It's incompatible with life. So they usually don't live more than a few hours or days. And this is also going to be elevated AFP. And here's a picture too. You can see that it looks like there's no skull or brain. Encephalocele is going to be a skull defect with exposure of the meninges and the brain. And I just wanted to point out these objectives that Dr. Chestnut puts in here: discuss the features, complications, and preventative measures in treatment of neural tube defects. Treat this like it was a question, because that might be a question that he asked on the exam. So here we have a picture. So it's almost like a meningocele, except it's of the head. It's usually midline on the base of the skull. So here's some pictures. And all of these neural tube defects can be prevented with the use of folic acid. And so the CDC recommends that women of childbearing age, whether they're going to get pregnant or planning to get pregnant or not, should be taking folic acid. And definitely women with a high risk, let's say they've had another baby with it, should consume more folic acid than the normal female. Weight control, diabetes control, always important. So this is probably a really important question, super easy. How can we prevent myelomeningocele or spina bifida or any of these issues? And the answer is folic acid. Okay, persistent cavum septum pellucidum. This is a midline structure separating the horns of the lateral ventricle. The cavum septum pellucidum is filled with septum pellucidum, and usually it fuses by 6 months after birth, but there may be a persistence in 15%. Usually it's very asymptomatic, but it can be associated with some psych disorders as well. So we can see these differences. Okay, Dandy-Walker malformation. This is really important to know. That's why I have a star. There are 3 components, either complete or partial agenesis of cerebellar vermis, and that cystic dilation of the 4th ventricle and enlarged posterior fossa. So let's look at this. So first, there's going to be complete or partial agenesis of the cerebellar vermis. So if we look right here, there's barely any cerebellum. There's going to be cystic dilation of the 4th ventricle, And so we can see almost cyst-like formations forming. And then a really big enlarged posterior fossa, like a big cyst. It can cause hydrocephalus because of the pressure on the third and fourth ventricles. And as you can imagine, a lot have cognitive disabilities because if we look at this, we're compressing all of that brain tissue. Holoproencephaly is a failure of the forebrain to divide into cerebral hemispheres. So there's one lobe at the brain, and they've got facial defects as well. So cleft lip and palate are very common. Also, cyclopia, that just means one eye, like cyclops. That's where that came from. And then trisomy 13 and 13 and 18 both have some of degree of this as well. So I would know probably cleft lip and palate are common with this. And of course you can see as these spaces get bigger, of course it's getting worse. Mutations in sonic hedgehog can cause some of these cases, and you can remember that back from MFM 1. Okay, macrocephaly. I remember this being important for the exam. And macrocephaly is a head circumference greater than 97%. And so on the exam, it may ask, what is the most common form of macrocephaly? Or a patient presents to you with macrocephaly and is like maybe their pediatrician was worried about hydrocephalus. What is the most common cause of macrocephaly? And the answer is familial. So big heads get inherited. Here's a big head, and here's also a big head. So of course you have to check for hydrocephalus, make sure that they don't have it with an ultrasound or MRI, but most likely it's a familial cause that causes these big heads. And usually the kid just grows into it. Microcephaly, the most common cause would be fetal alcohol syndrome. So make sure you know that as well. Also intracranial vascular insults, genetic disorders, Zika, that was really popular, I think like 3 years ago. You would hear about like people not being able to travel if they were pregnant because of Zika virus. And then craniosynostosis. And this is in my like pediatric neurosurgery, this is a surgery that we actually do. So the sutures are supposed to be open, except the myopic suture, which is right here. That suture is closed by birth, but all of the other sutures on the head are open. But if these sutures were to close early, then you may have, like, if it's our sagittal suture, you may have like a bowing and a prominent forehead and a prominent occipital bullet, and it almost looks like a canoe shape. So that's just one example of craniosynostosis. There's different types of that too. That's just so you know what that means. Okay. Lissencephaly. I think it sounds that the two S's sound smooth. So it's a smooth brain without sulci. So if we look at a normal brain versus this one has no gyri, no sulci, and they have profound mental developmental delays. Let's think about this. So if we have all of these sulci and gyri, this is increasing the surface area of the brain because we've got right here, looking around like this. This has none of that. So this would cause mental delays due to just a decreased surface area for one. at least. So make sure you know these pictures. Causes could be X-linked or spontaneous genetic mutations. Okay, AVMs. This is a tangle of abnormal vessels containing arteries and veins. So it's almost like just a big net wad of these vessels. It can occur anywhere in the body, but it's most common in the brain and spinal cord. A lot present with bleeding. They can have headache, seizure, or almost stroke-like symptoms, paralysis. A doctor I worked for, he was an OBGYN for 8 years. And then in the midst of surgery, he became paralyzed on one side and ended up having an AVM. And he had to have surgery, and it deemed him not able to operate anymore. So he became a family medicine doctor. So that's a scary, sad side. But anyways. And you can see it from this section, you can see more, all those vessels. Okay, Chiari malformations. We talked just a minute about that in Dr. Gassler's lecture, but females are more common than males. Type 1 may be asymptomatic or develop symptoms later, and symptoms could be headaches, dizziness, muscle weakness and numbness, vision problems, and balance. It's associated with hydrocephalus, sphingomyelia, tethered cord, and scoliosis. So something also that you may hear on rotations, it's like not the nicest thing in the world, but they sometimes call them Chiari crazies because these patients always seem to have problems or think even after surgery that there's something wrong. And they seem to complain more, and you can never fix them. So you might hear a doctor say that. So here's our syringomyelia, which is that fluid collection. So once they fix one of these Chiari malformations, and what they do is increase the size of the foramen magnum so that there's space, this extra CSF in the midst of the spinal cord gets reabsorbed over months, year, and looks back to normal. But the way to sort of remember it, it kind of looks like a syringe in there. So syringomyelia. So here's our Chiari type 1. The lower part of the cerebellum, which is the cerebellar tonsils, extend through the foramen magnum, but not the brainstem. So the brainstem isn't herniating, just the tonsils. It can also be acquired through CSF loss. And you get this tinted looking cerebellum. Okay, Chiari type 2 is what we also call Arnold-Chiari malformation. Both the cerebellum and the brainstem are going to be extending through the foramen magnum. So here's our end of our foramen magnum, or through our skull. So here's our foramen magnum, and we can see that the cerebellum and the brainstem are herniating down. So as you can imagine, in our brainstem, we've got lots of important cranial nerves. And so dysphagia, we've got our cranial nerve 10, 9, aspiration, vocal cord paralysis, and respiratory problems. Our respiratory center is located here. And it's important to avoid extreme head flexion because that's going to put more pressure. And it's treated with decompression surgery, similar to Chiari type 1. Type 3 is going to be very severe. There's going to be occipital cephalocele involving the cerebellum and the midbrain and cord, resulting in severe neurologic defects. But this is super rare. then the prognosis would not be good. Chiari type 4, I was actually reading on Chiari in a pediatric neurosurgery textbook because we were going to do surgery. It ended up getting canceled, but they were saying that Chiari type 4 is actually no longer, or I read in the textbook and then I also read on Up to Date, Chiari type 4 isn't a thing anymore. Like it used to be called Chiari type 4, but now they're saying it's, I guess, so rare that, or they may not live, that they're just doing away with the name. But it's an incomplete, underdeveloped cerebellum, sometimes with exposed parts of the skull or spinal cord. And that's what it says right here. Probably a different etiology. So I would make sure I would know probably Chiari 1 and 2. They're the most important. Okay, our neurological exam. So this professor is actually new this year. So I went through his stuff today, and the important things in the neuro exam that you need to make sure that you do is the mental status, cranial nerves, motor, reflexes, cerebellar and gait, and sensory. And you'll learn how to do a great neuro exam in EPC. I think that you guys did it a little bit last year, but then you go over it again this year. So mental status, it's not just their chief complaint, like headache, it's how they feel. So how are they doing today? How is their behavior? Are they you'll see sometimes on charts, oriented times 3. What does that mean? Do they know who they are? You ask them where they are. Do they know they're in the hospital? Do they know the date? Sometimes do they know the president? Questions like that. Cranial nerves, you can get really good at that in EPC, and we'll go more over it. Motor, reflexes, cerebellar, gait, and sensory. So mental status, is our memory short-term versus long-term? Remember, we store our memory in the hippocampus, and then we also need to make sure they have attention or concentration, which is sometimes lacking with us medical students learning all this stuff. Examples are serial 7. So give them a phone number. Can they tell it back to you in a few seconds? Or serial 3s. Remember dog, duck, apple. Remember those and we'll come back. And then can they repeat them later? Can they say their months backwards? Can they spell the word world backwards? Emotion, make sure it's appropriate. Sometimes with some of these disorders, maybe their emotion isn't appropriate. Another thing to know about the mental status exam is it's important in psych, and you'll get that in spring semester. But if we look at the like Pick's disease or Alzheimer's or Parkinson's that affect our frontal lobe, maybe our emotion will be off. So in Pick's disease, it's also called frontotemporal disease. It is associated with a behavior change. Alzheimer's has behavior changes later down the road, and then Parkinson's, Lewy body dementia, it's also going to have a later cause. And you'll learn more about those later, so don't worry too much. And then you can assess this with the MMSE screening test. And I think there was a copy in your PowerPoint. Okay, so here's all our cranial nerves, and this is from anatomy. I just included this big table so you can like go back and remember like where it came from and like what it does and everything and what muscles. So let's look at what he had in his lecture. So cranial nerve 1, olfactory. Clinical correlates, if there's a lesion, it's going to be anosmia, so can't smell. Example, COVID-19. or if they get hit, maybe a runny nose. Optic nerve, cranial nerve 2, blindness, loss of vision. They may have papilledema with a lesion. Papilledema is shown up in pseudotumor cerebri, and you'll learn more about that. But basically, I actually had a patient last week with this, so it was kind of cool to learn it in school and then see it on a real person. She was 15. She was morbidly obese. So it's a type of hydrocephalus. It is that it's communicating, so there's no obstruction, but she just has too much CSF. So she lost all of her vision. She had headaches and she was vomiting. And we ended up putting a shunt in her back, and the next day she could see. And she had severe papilledema because there's so much pressure of that CSF, it's like sitting on the optic nerve, that it causes the vision loss and the papilledema. Cranial nerve 3, oculomotor. If there's a lesion, their eye would be down and out. They would have drooped eyelids and issues with the pupil constriction. So clinical correlates, knowing the difference between conjugate and deconjugate gaze. So if a patient has strabismus, they would have deconjugate gaze. So conjugate, their eyes move together and it's normal. In strabismus, let's say a medial strabismus, they may have one eye turned in and the other one moves. Nystagmus is, of course, the eyes shifting or up and down. And then intranuclear ophthalmoplegia, and we're going to talk about that in a little bit. Trochlear, it's still cranial nerve 4 and cranial nerve 6. All 3 of these help move our eye. Cranial nerve 5 is trigeminal neuralgia. And I think that you're going to talk more about that, I think, next week. If not next week, the week after. And then our corneal reflex coming in is going to be V1. So touching the eye. And then that's the afferent. The efferent is going to be cranial nerve 7. So to cranial nerve 7. Example would be Bell's palsy. Remember all of the motor, 2 temporal, Zanzibar, zygomatic, bod, buccal, motor, marginal mandibular, and car, cervical. And then that gives our motor. Taste to 2/3 of the anterior tongue. So this could go away, of course, with COVID. Provides stylomastoid and posterior digastrics too. Cranial nerve 8, vestibulocochlear, hearing and balance. So in benign positional vertigo, this may be off. And a test to test for that would be the Dix-Hallpike maneuver, and then to treat it is the Epley maneuver. And they do that a lot in ENT. Glossopharyngeal, cranial nerve 9. A lesion would cause difficulty swallowing or no gag reflex. Remember that goes to the stylopharyngeus, so it helps open. So singing would be kind of an example. Cranial nerve 10 is our vagus. It gives taste to posterior 1/3 of the tongue. Goes to our carotid baroreflexes, chemoreceptors, and our gag. Cranial nerve 11 goes to our SCM and also our trapezius. So you test that by shrugging. And then a patient with torticollis or a tightening of one could have potentially a cranial nerve 11 problem. Our last one, cranial nerve 12, hypoglossal, is with our tongue movement. So if somebody sticks out their tongue and it moves to one side and it's atrophied on one side, then the tongue is going to deviate toward the affected side. Okay, I know that's a lot. Just make sure that you have the clinical correlates for each of the cranial nerves. And know the number and the name. I think that's probably important. Okay, so our motor exam, if there's atrophy, it could be something like thenar atrophy and carpal tunnel. Tone, if it's spastic, it could be muscular dystrophy or cerebral palsy. You can see here's a patient with cerebral palsy. Rigid, they call it cogwheel rigidity. So you lift their arm and they're like this, that's Parkinson's. Or if flaccid, they have no tone in a coma. Tongue fasciculations are common in ALS or spinal muscular atrophy in pediatric patients. And this bottom picture is an example. So muscle strength grading is right here. I've also got it here on the next slide. So know that 3 is against gravity. 4 is going to be less than full strength, and then 5 is full strength. No gravity is going to be 2, contractions 1, and flaccid is 0. So make sure you kind of know that at least 3 is gravity, and then you can kind of guess the rest. Okay, reflexes. These are super important to know. A normal reflex is a 2. So 2 out of 4, or you would put 2 plus. So here for strength, if they have full strength, it would be 5 out of 5 strength. If they've got normal reflexes, you'll say 2 plus reflexes. If they have the exaggerated big reflex, 3 plus. If they have no reflex, it's 1 plus. And that's how you say it. Biceps is C5, brachioradialis is C6, and triceps is C7. Our patellar is going to be L4, and our Achilles is S1. Make sure you know these localizations. And this is not only important for this class, but also MSK. So make sure you really, really know this because they test heavy on it. Okay, cerebellar, look for a tremor. If they put their arms out or hands out and they already have a tremor, that's essential. And then if they continue to have a tremor as they go pick up something, that is a baseline tremor, essential tremor. A resting tremor is common in Parkinson's. So they've got a tremor at baseline or it's like a pill rolling phenomenon like this. And then they go to pick up something and they no longer have that tremor. Finger to nose, put your finger to your nose, back to my finger, to your nose, my finger. That test. If they can't get it, they overshoot or they undershoot, then that's dysmetria, so against meter. So they get the distance wrong. Heel to shin is a test. Rapid alternating movements, which if they miss is called dysdiakinesia. And then some other tests that you can also look for that aren't necessarily cerebellar, but I just put them here, are Romberg tests. So they close their eyes, and then usually you can put these two together. Close your eyes and put your arm out, and if they've got an arm that starts putting over, that's a positive pronatal drift. Or if they start swaying, it could be a cerebellar problem, but it also could be a muscular problem or a hearing problem or balance problem, like a vestibular problem. Gait. When you're assessing for gait, first make sure that they walk, let's say, to the door or down the hallway and back. So walk to the door and back, make them walk both ways, see the normal twice. Then walk to the door on your tippy toes and then walk back on your heels. And then also number 4, make them walk in a straight line, heel to toe. So if they can't walk on their tippy toes, that means that they can't plantar flex. So it's an S1 problem. And so they've got a problem with their gastrocs. You're testing their gastrocs, so it's an S1 problem. If they can't walk on their heels, they're not able to dorsiflex. So when you're testing it, the extensor hallucis longus would not be able to go up or contract, so it would be an L5 problem. Walking the line is a combination of things, but they're having trouble balancing. In his, he put short shuffling gait is Parkinson's, so it's important to see, okay, are they shuffling? You know, they've got this tremor that goes away when they touch something. Maybe this is what they've got. Foot drop is common in MS and also Charcot-Marie-Tooth disease. And I think that we go over Charcot-Marie-Tooth next week and then MS today. Okay, sensory. If it's to sharp, that's going to be the spinothalamic pathway. If it's dull, it's going to be the dorsal medial lemniscus column. Light touch is like stroke patients, 2-point discrimination. Also is a problem with stroke patients. If they're having a stocking glove distribution sensory loss, so basically their hands and their feet, or like wrist and ankles, they have a loss of sensation, then that's common in diabetics because of the accumulation of glucose on those nerves. Sort of is an easy way to think about it. Posterior column, like vibration, proprioception degeneration. And can be example with alcoholic patients. We've got spinal cord transections or cauda equina. They're not going to have the anal reflex and they're going to have bowel and bladder incontinence. So here's some sensory examples. And so here's our sensory levels, just knowing kind of gross landmarks. Okay, pediatric reflexes, or when things go wrong. So in a pediatric patient or a baby, they should have these reflexes. That's normal. But when it's an adult and they start developing these reflexes, it's not normal, and we should be thinking that there's a problem. So glabellar tapping on their head in a normal person should make you blink. Sucking, they always check babies suck, make sure they have a good suck, and that's cranial nerve 9 and 10. Snout reflex, tap under the nose and it starts making a snout shape. Brooding, I've seen them check this in peds. They'll put their finger on the cheek and the baby moves to suck. Palomental, the mentalis contracts when the thenar eminence is stimulated. And then grasp reflex is literally grasping. Okay, he put this on his, so I thought I would include it. Test questions he may ask, visualization of the question stem clues. I don't really know what that meant, but I included it. Cranial nerve distributions, make sure you know those. And then the scales of the motor and reflex. So remember, 5 out of 5 is normal for motor, 2+ for reflexes. Okay, tools of localization, everything. This is the like one lecture I think that people really dread. But I think that you don't have to, they tell you it's important to know, go all the way back and know all of your neuroanatomy again. but I think it would be more important to make sure that you know his examples. If you have time and you can go over all of neuroanatomy, that's great. If you don't have time, make sure you know the examples. And I included just a few more examples just in case. So when you're trying to figure out what's going on, we don't have, let's say the MRI machine is down, even if not, make sure you get a good rapport, be organized, get information from the patient and family members, and then you'll be able to figure out what location maybe this lesion is in. Always include your neuro exam and know your dermatomes. Okay, upper motor versus lower motor findings. It's really important to know these. So upper motor findings, we're going to have hyperreflexia. So 3+, 4+ findings, reflexes. Increased tone and spasticity. So everything's going to be contracted. There's not going to be any atrophy. It's almost like they're working out because they've got increased tone. And then there's going to be signs like positive Babinski. Lower motor signs are going to be decreased tone, flaccid paralysis, hyporeflexia, or muscular atrophy, and then fasciculations. So I would know like positive clonus for upper motor neuron, hyperreflexia, lower motor hyporeflexia, and then fasciculations. Here is what he had, his upper motor versus lower motor neurons, and just sort of some definitions. Apraxia is inability to perform learned acts without having the weakness, or motor secondary damage. So here's some of his examples. What lesions could produce face, arm, and leg weakness on contralateral sides of the body without associated symptoms? So that's going to be completely purely motor. So that's going to be located in the posterior limb of the internal capsule pons and middle third of the cerebral peduncle. Okay, what lesion could produce unilateral leg weakness? So remember, it's going to be contralateral to the leg in the motor cortex, and it's going to be ipsilateral, same side below T1. A complete transection at the level of T10, for example, is going to, we can see transverse cord versus hemichord. So transverse cord, we're going to have loss of vibration, position, pain, and motor loss. Hemichord is going to be loss on one side. Bilateral leg weakness. An example of this would be bilateral parasagittal motor cortex, or thoracic spinal cord, or cauda equina. I'm going to kind of sort of start like skipping through some of these because I think these are important, but not as important as the next ones. Okay, as these cases. So we've got a patient that presents to the ER with acute onset of weakness, lower face, weakness of the right lower face and right upper extremity. He can follow commands. His speech isn't great. His eyes are deviated to the left, so I would probably know that. It's always important if you see eyes moving in a different direction, that's going to give you a clue. Decreased sensation to pinprick on the right side of the face, and right upper extremity. His muscle stretch reflexes in the right and lower are brisk. He has Babinski sign on the right and reflexes on the left side of the body are normal. So I said the eyes are important. So his eyes are deviated to the left. So Usually eyes deviate toward the lesion, so they look to their lesion. So it's going to be a left-sided lesion. We also know that Babinski's is on the right, and we know that that's a contralateral sign. So that further shows that it's on the left. So we've got face and upper extremity on the right. So let's see. Let's look at these important features. We already said the eyes. So we know we've got a central nervous problem. And right here, we've got a tumor in the brain. So we know it was in the brain because we're already having contralateral face and body, and contralateral reflexes, and then the eyes deviating. So our diagnosis is going to be a left in, I said tumor, but it could be a tumor. But in this case, it's going to be an infarct. Acute left middle cerebral artery, ischemic infarct. So if it was a anterior cerebral, then that's going to be affecting the legs. But since it's also affecting our arms and face, it's going to be a middle cerebral. So if you think of the homunculus, we've got our legs and then we go down to our arms. Okay, case 2. We've got a man that develops paralysis of his lower face, upper and lower extremities, and complains of double vision. You notice ptosis on the right eyelid. When you lift the eye, you notice that it's deviated laterally and he can't adduct the eye past midline. He can't move the eye up or down. The pupil is dilated on the right, and the left eye isn't, and reactive to light. The left eye movements are normal. He's got significant weakness and a Babinski's on the left. Reflexes are normal. Sensory exam is normal. So we know we've got a big pupil on the right. Babinski's on the left, and we have ptosis. So thinking maybe stroke, maybe on the right. So it's important to know that we have crossed findings. There's motor loss on the left and cranial nerve abnormalities on the right. So since we have 2 different sides, this is suggestive of a brainstem lesion. So oculomotor is involved on the right, and then corticobulbar and cortical spinal tracts are going to be affected. So here's our anatomic location, and here's our MRI correlate. So our diagnosis is going to be a right cerebellar peduncle infarct, which is Weber's syndrome. Other syndromes are Wallenberg's upper medulla, Miller-Gubler syndrome, ventral pons, Foville, inferior medial pons, Benedict's, tegmentum of the midbrain, and then Perrin's, which is where they look up. So mesencephalic tectum. So small lesions can damage multiple structures in the brainstem. Usually the lesion is on the same side of the brainstem as the cranial nerve abnormality. So that's just something to think about. Case 3, 23-year-old has a 2-day history of progressive lower extremity weakness. She can't walk or urinate, and she feels numb from the waist down. She has complete paralysis in the lower extremities and loss of pinprick from the navel down. She has no vibratory sensation below the waist. She has positive Babinski's in both feet, and her patellar and Achilles reflexes are graded 4 out of 4. Upper extremity reflexes are normal. The remainder of her exam is normal. Important features. We've got upper motor neuron findings, in a sensory level. abnormality, and then she can't urinate, so that's a neurogenic bladder. So we can see that she has an acute transverse myelitis. So it's a complete functional transection of the spinal cord. And I think this one is one of the easier ones to find, and they like to test it more. So I would know transverse myelitis. Okay. I'm going to sort of skip to the important features instead of reading that whole thing. There's lower motor neuron findings like fasciculations, normal reflexes, and abnormalities are isolated to the peroneal nerve, then it's going to be located right there at that, like, let's say, lower extremity. And in this case, there is a conduction block to the fibular head, so compressive neuropathy. So that diagnosis is acute right peroneal neuropathy at the fibular head. Okay, so those were like examples I just had, and these are his from class that you guys already have. And I know that he's went over these with you. I don't know if it would be super important for me to just go over them again, but I put them all in my PowerPoint slides so that you'd be able to read them and go over them. But I made sure that I knew them for the test. Looking at this, knowing that they've got distal upper and lower extremities sensation loss, that's the stocking glove distribution. So most common diabetes, sensory motor peripheral neuropathy. In this one, we've got a spastic gait. Babinski signs are positive and increased tone, and lower leg reflexes increased. So we've got this degenerative spine disease. Here's a spur osteophyte pressing on our spinal cord, as you can see right here. Case 7, I sort of changed it a little bit from your PowerPoint slide. So you might get a question like this, Scott, and I want to point out too that when you're taking the exams, it's different than first year. These are going to be sort of cases when you are presented with questions. So it'll give you like all of their symptoms, and then it might ask you a treatment or ask you what's the next best step I should take, or what lab should I order, or what imaging should I order. And you get to play doctor now and figure out what to do. So instead of telling you that this patient has papilledema, they may just show you a picture and say, the exam reveals an eye exam notable for the picture below. So they may not tell you it's papilledema. So make sure that you know what papilledema is and what it looks like. And we'll learn more about glioblastomas next week with Dr. Campbell. Okay. I'm going to just skip over these. Since here's again acute transverse myelitis, so I can make sure I know that. Since we have so many cases, and I think he goes over it really well. Okay. So now we're on multiple sclerosis. It's a lifelong disease of the central nervous system. Most people have heard of MS before. It's the most common cause of demyelinating disease in adults. There's 3 different types: relapsing remitting, secondary, and primary progressive. I would say usually with questions, and I know that we used to use ComBank my second year, and then I also had ComQuest and UWorld. And they love to ask MS questions, and it's always relapsing remitting, usually because it's easier. So let's say a patient had vision loss for a few days and got better. And then they're starting to have weakness in a leg 6 months ago. And then today they're having some more leg weakness. What do I treat them with? So this is saying they've got these problems, then they get better. Then they have problems again, and then they get better. So this is an inflammation, destruction of the myelin, and destruction to the axon. So here's some symptoms. Vision, sensory weakness, pain, dizziness. They're really just a broad variety of symptoms. They may have that sudden vision loss that comes back, the optic neuritis. It may have spasticity. Temperature may trigger it, which is a Toff's phenomenon. So physical exam may have intranuclear ophthalmoplegia. So you can see leading eye has nystagmus, and then there's a failure here of adduction. So this is an MLF demyelination. They also could have Littermite sign, which is like an electrical shock sensation radiating down from the neck. But diagnosis is really, you can use MRI, you can use lab values, you hear all their symptoms, but really all of this helps you, but it's a clinical diagnosis. So there's no lab finding, there's no MRI that's going to tell you if they have MS. There are some things that can lead you to suspect it on MRI with contrast and flare enhancements. There's periventricular white matter disease. So right around the ventricles, you can see this white matter. And then also on the sagittal cut, there's Dawson's fingers, is what it's called. From being on rotations for over a year now, I have also noticed that you'll see a lot of MRIs that say periventricular white matter disease, clinical correlate of MS, but they'll be like age 90. So as you get older, you'll start developing some different changes like periventricular white matter. So that doesn't tell us that they have MS. They're just older and their brain's changing. A patient could also have MS and not have this white matter disease. Lab values are IgG, myelin basic proteins, and oligoclonal bands. Treatment, relapses treated with high dose steroids to decrease that inflammatory response, which also is the treatment for optic neuritis if they ask you. And then also lots of disease modifying therapies. Beta interferons, non-interferons, and monoclonal antibodies. I wouldn't necessarily know these names. I don't think that's important, but I would know that you treat relapses with steroids and you treat optic neuritis with steroids. That's the most important. Transverse myelitis, this is the third time it's been brought up, so it's super important. It's a sudden onset of weakness and sensory disturbance below the level of the lesion. So like loss of sensation, usually found at the nipple line or below the umbilicus. And usually a sphincter dysfunction is common. Muscle stretch reflexes may be suppressed initially, but eventually become hyperactive. Diagnosis is with MRI, and you treat with high-dose steroids. So if a patient starts having this weakness and sensory distribution, let's say at the nipple line or belly button line, make sure get them in an MRI, but treat them with high-dose steroids immediately. So first step, steroids. Second step, then we go to MRI. Neuromyelitis optica, Devick's disease, is optic neuritis plus myelitis, and you're thinking, okay, optic neuritis, I was thinking of MS, but now there's another disease with it. It can cause blindness in one or both eyes, weakness, spasms, uncontrolled vomiting and hiccuping, and bladder or bowel dysfunction. So that sounds really similar to MS, but there's no brain involvement. So here's a chart, and I highlighted some important things. So the attacks for NMO are usually very severe. The head MRI is going to be normal versus multiperiventricular white matter lesions in MS. And then the antibodies, MOG and aquaporin 4, are going to be present with NMO, but not with MS. So make sure you know the difference between those. I feel like you might ask a question on that. PML is an infection caused by the JC virus in patients with AIDS and can be also transplant patients. It's characterized by patchy areas of demyelination of the white matter. And you can see these patchy areas. It's important to know that this is patchy versus periventricular, as we had seen in MS. Central pontine myelinolysis, he put a big thing that it's super important for you USMLE. So I would make sure I knew it since he wrote that on the slide. It's a neurological disorder that is caused by a quick correction of hyponatremia. And I included this from first aid. Sorry about that. And this patient may be alcoholic, comatose, renal failure, malnourished, and they've got really low sodium. They give them sodium too quick, and they ended up having this central pontine myelinolysis. So this little poem or saying is how I remember it, and I still remember it from learning it second year, and I think it's just super easy way of remembering. So from low to high, your pons will die. So if you take sodium that's too low and you increase it too quickly, you have your pons will not work anymore. And then from high to low, your brain will blow. So you'll have cerebral edema and herniation. So low to high, pons will die. High to low, your brain will blow. That'll help you remember it. Because you need to know if they started out with hyponatremia and a quick correction, or if they started out with hypernatremia and quick correction. I'm including these. This is what he says are really high yield test topics. So I'd make sure that I knew all of these for the exam. I personally did not see these on, I didn't find that they were like super important for like some test I took or practice questions, any practice questions that I did studying for boards, but I still think it's probably pretty important to know, at least for your exam. And that is it. So that's our last slide. If you have any questions, make sure, please email me, please ask me anything, and we'll have the rest of the lectures on next week. Thanks, guys.